Hello, everybody. Welcome back to Psychedelics Today. We're really excited to have our guests on, Dr. Reid Robison and Dr. Steve Thayer from Novamind. Welcome, guys.
Thank you. Hello.
Thanks.
We'll start off with some intros. Steve, since you're the left of me right there, let's start off with you. Can you give a little intro about who you are and some of your work?
Yeah, so I'm a clinical psychologist. I have a Ph.D. in clinical psychology, and I started my career in psychology in the Air Force. So clinical psychologists have to do like a 1-year internship / residency to cap off their training, and I did mine with the military. So came in as a captain, was an Air Force psychologist for 4 years. Decided pretty quickly that the military life wasn't for me. As much as I enjoyed helping out active duty and retired military members and all the cool experiences I had, I decided I didn't want to be part of a giant bureaucracy. So yeah, I got out of the military, went into private practice, and from there developed a research interest in psychedelics, and then found my way to work with Novamind, which will soon be Numinus, which we can talk about, in ketamine-assisted psychotherapy, and involved in a lot of the clinical trials that we're doing there. So currently my role is the clinical director of education and training for Novamind, where I make sure that all of our clinicians are trained well in how to do, in our case, ketamine-assisted psychotherapy. And I'm also the lead facilitator for our psychedelic clinical trials, which, as I said, we'll talk about more in detail, but that's, psilocybin, LSD, ketamine, and the like.
Yeah, I'm excited to hear more about the LSD trials. It's exciting. And then Reid, we'll pass it over to you.
Sure. So I'm a psychiatrist and chief medical officer at Novamind. I started my career in academics doing clinical trials and had a genetics lab at the University of Utah. Got a little impatient with the academic pace and the grant writing and left to do things more entrepreneurial, I guess. Started working with ketamine about 11 years ago. I think I got my first grant to study it in 2010. Did a clinical trial for Janssen, actually, of IV ketamine for treatment-resistant depression back in 2011, and was just fascinated, not only because here was a new mechanism, but because of the experience during. I got to sit with people back then, and this is before we were really pairing it with therapy. So a couple hundred clinical trials later, I've veered more into the psychedelic realms, working with ayahuasca for the past few years in retreat settings, both as medical support and psychedelic therapist. And I was brought on by MAPS as the coordinating investigator for their eating disorder study using MDMA, helping them get that off the ground. But a few years ago, I co-founded a clinic and research site network called Cedar Psychiatry. We joined forces with Novamind back in 2020. And then fast forward till now, we had the recent announcement of being acquired by Numinus, which is exciting news. And so that's I guess, a brief snippet of my background.
Thank you for that. So I know, you guys had some big news with Numinus lately. I know our other team member, David Drapkin, chatted with Peyton from Numinus about it, but would love to hear from your side of things. What is this big news, and can you give us any updates around it?
Yeah, we're excited about it because we found this partner, this like-minded company in the space working on both the clinical front, delivering psychedelic-assisted psychotherapies, starting with ketamine and with some research efforts, with MAPS and with psilocybin, and then just this overall vision we share. So we've got a great relationship budding and these complementary businesses to create a North American footprint with clinics now spanning, I guess it's up to 13 mental wellness clinics, 4 research sites, and 1 bioanalytical laboratory that Numinus has to create this platform that's scalable, bringing about this new standard of mental health care with psychedelic therapy expertise.
It's really, really exciting. Yes, congrats again on that. Steve, do you want to share anything about that news as well?
Yeah, Reid's closer to it than I am. I'm just excited to see what happens, because joining forces like this makes us one of the bigger mental health companies that specializes in psychedelic medicine in North America for sure. So I'm really excited to see what we can do with the resources, combining the resources, both in the provision of, the best in class psychedelic assisted psychotherapy and cutting edge clinical trial research in psychedelics.
Yeah, and I guess like what was the spark to have this merger?
Well, there's a lot of work to be done in the space. There's not a clear cut leading force, setting the standards, forging the path with like the best practices and protocols. We've delivered thousands and thousands of both ketamine assisted psychotherapy sessions and esketamine dosing sessions, and Numinus has their growing clinic network too. So it just made sense, especially in this phase of the market with consolidation, synergies, collaboration seem to be the best path forward. And so we've found such a great partner in Numinus, and are jumping in with enthusiasm to tag team this challenge.
It's wonderful. Just thinking about scalability, I wonder if you could maybe share some thoughts around this, because I think this is a challenge for maybe some of the psychedelic space to think about how do we scale these treatments. And I know I think I've chatted about it on your podcast about the education side, but then also the delivery side. So I wonder, maybe Steve, if you wanted to chat a little bit about the education, then we can maybe talk about the clinical scaling side.
Yeah, no, I'd be happy to. So, for those of us that work in this space and that follow this space, one of the big challenges, and MAPS speaks to this challenge too, is that uh, we're going to need to have well trained professionals to deliver really high quality psychedelic assisted treatment, psychedelic assisted psychotherapy. And like for now, as far as we know, there's no training program that has been certified by an international or national regulating body that will give you a license or certificate to practice, right? That you can say, I went to this training, therefore I am certified to do ketamine assisted therapy or MDMA assisted therapy, except for maybe the MDMA assisted therapy training that MAPS is offering, because they're going to have some kind of proprietary authority over um, the way that MDMA assisted therapy, at least for PTSD, if it gets FDA approved, is delivered. So, we wanted to jump into the education space like a lot of people like you folks have, just to give people some foundational knowledge and understanding to prepare them so that when and if some kind of official education and training certification comes out, they can go in there with confidence, having some exposure already. So, we've come up with what we call our Foundations of KAP, or Foundations of Ketamine Assisted Psychotherapy training course, that we're going to be launching here in the next month or two. So if people are interested, they can go to cedarpsychiatry.com/edu, and you can put your name on the wait list. And we have a variety of offerings, but they're all, for now, going to be structured around ketamine assisted psychotherapy, just the basics.
Awesome. And I definitely want to come back to that later in the interview to get a little bit more details, but I guess we'll stick on the scaling conversation. And Reid, like, what do you see on the clinical end? Like, how do we scale psychedelic therapies?
Yeah, so it's been a fun process to reflect on since we started Cedar back in 2017, 2018 or so, offering KAP. And then when S-ketamine Spravato came out, we made the decision to offer that as well, helping people leverage their insurance. And like we've given that 10,000 times since then. And
Wow.
Every one of them covered by insurance, leveraging patient assistance programs. We've gone at it with this approach of accessibility and quality. So our standard model in a given clinic is to have, in addition to the private room KAP session options, to have this even more accessible, affordable way of doing it, where there are usually like 4 ketamine bays. Like in the clinic where Steve and I are in Draper, there's a glass front, a nurse's station, where there could be clinicians there, medical assistant or nurse there, and staggered appointments to get people started, set intentions, get the music set up, the eye shades, the dose figured out, deliver the medicine, hold space, one-on-one if needed, but sometimes we can do that from the other side of a glass wall and have frequent check-ins as needed, but to be able to offer it to more people, because scalability has been a challenge, and we feel really good about how we've been able to set the protocol up to maintain a high standard of care and also open up this much needed therapeutic option to so many people. And then we've replicated that across multiple clinics, starting in Utah, because it was within driving distance. We could be to any of our 8 clinics within an hour or two, and checking in on things, bringing people in for trainings with me and Steve and others. We'll be doing a workshop next week, in fact, on psychedelic assisted psychotherapy in one of our clinics, bringing clinicians in. So it's been a really fun and creative process to figure out different ways of delivering this. And I think we're just at the beginning, the tipping point.
Yeah.
Another, like Kyle, another thing with respect to accessibility that we're trying to create is group offerings. I zoned out, so I don't know if Reid said this, but one of the things that we do is we have a service we call Frontline KAP, or Frontline Ketamine Assisted Psychotherapy for frontline healthcare workers who've experienced distress, trauma, vicarious trauma because of their work, particularly in response to the COVID-19 pandemic. So we offer that in a group format, where people get introduction sessions, they get experiential sessions with the medicine together in a group, and then integration sessions. And we've found that that's been really helpful for people, and it also increases accessibility because we got a couple providers to several patients or clients. And then we offer online integration groups as well, where cool. 1 or 2 therapists lead an online group that's relatively cheap and easy to access.
Yeah, I'm really excited about more group work. And I guess, are you finding any differences there with group versus individual therapy?
Anecdotally, it's so rewarding to see people go in as a cohort and face this new wild experience of often their first psychedelic dosing session together, to prepare together. It's reminiscent for me of the power of like a group setting, working with, say, ayahuasca in the jungle, for example, and how special that is, and how we can really pay attention together to the preparation work and the integration. And we have analyzed a lot of the data. We have a group ketamine assisted psychotherapy paper that's in final reviews for publication on eating disorder.
Awesome.
We're about to submit our first paper on frontline KAP that Steve just mentioned, where we show some really exciting reductions in trauma measures, some increases in resilience, and the satisfaction feedback from clients is really striking. But what do you think, Steve, from your end on the group work?
I think the groups bring with them the same advantages and challenges that sort of regular group therapy has over individual therapy. Some people really enjoy having especially if you compose the group really well, which we tried to do with people with similar backgrounds and similar struggles. The group cohesion is something that is hard to, like that. There's a benefit there in positive bonding relationship and group cohesion that's hard to replicate in individual therapy. And we've had clients say, I had an experience with a group member that was more helpful than anything you said, Dr. Thayer. And like that's what we love about group work, is that people can get a benefit from their group, their peers, that is that we can't give them as the clinicians, just because of the nature of the relationship. That being said, there's also unique challenges. And sometimes these challenges are great triggers to follow and explore. But, we had one client who remarked that another group member who was making a lot of noise during one of the dosing sessions was distracting for his process. And it was hard for him to sort of follow his intention into his experience and explore it. And like I said, it gave us opportunities to process that experience, which, as an old supervisor of mine used to say, it's all grist for the mill. It's all good to work through. But yeah, I think it brings with it the same advantages and some of the same challenges that group work has generally over individual therapy.
And how many people are typically in your groups? I'm sure it varies, but what's like your max?
Well, now that we're offering this commercially, we started out as a pilot that was going to be 4 to 6 people in a group, but it was also during the pandemic, aimed at pandemic related burnout, stress, and trauma. So we limited it to 4 people, which was actually really, really nice to start there. But in this next cohort next month, I think we're doing up to 6 at a time. And yeah, that's been my sweet spot. I've been working with group KAP for 5-6 years or so, and I like groups of 4 to 6 personally.
And I'm curious around like your route of administration there. Are you using IM or sublingual lozenges?
Yeah, it's a really interesting and fun approach. This one took the frontline KAP because most of our ketamine work is either IM, traditional IM KAP, or we'll do a fair amount of psycholytic work with lozenges. And we do IV when it makes sense, or nasal spray with S-ketamine, of course, and when it makes sense. But this protocol was designed and actually dreamt up by Scott Shannon, who founded and owns Wholeness. Just such a big-hearted and smart, sharp mentor and friend who designed a protocol of sublingual dosing with liquid ketamine for the first 2 sessions, low dose, medium dose. And then on the third session, the third dosing session, we do IM ketamine. So what we'll do, go ahead, Steve.
I was going to just remark about that dosing strategy because we learned some interesting things. We liked the compounded troches or lozenges, but this just squirting a bunch of ketamine in somebody's mouth and then asking them to hold it sublingually for 12 to 15 minutes turned out to be kind of challenging for some of our clients, especially because ketamine tastes like, bile. It's just super gross. But then you salivate and then just the volume of fluid in your mouth grows. Yeah. It was hard for some of our clients not to swallow it. And then, so they had varying levels of absorption and depth of experience. And so I don't know what you think, Reid, but we've talked in the future, maybe not going that route. If we do sublingual administration, we might get the compounded lozenges instead, or just stick with IM because it's a more predictable trajectory of the experience.
Yeah. I mean, I'm partial to IM personally because of its predictability and smooth trajectory. But I didn't mind the variability. And the one thing is, if you're a prescriber of compounded ketamine, you know that when you prescribe a lozenge or a nasal spray, it has to be for an individual client, not for a clinic supply. So you would have to anticipate and give the time for it to be compounded and brought in or delivered to clinic. But in this way, the way we did it with sublingual liquid, you can have it out of the clinic supply and give it,
oh, that's interesting,
from the ketamine vial. So there's a convenience factor too. And less waste in that way.
Yeah. Oh, super interesting. Thanks for sharing all that. I'd love to learn a little bit more about this term you use, like FCAP, or maybe you brought it up before we got recording here, and that like framework.
Sure. Yeah. So FCAP is something we dreamt up in response to this question from so many of our clinicians of, how do I do KAP? Like we've been teaching and training on KAP for many years. And since then we feel pretty good at it, pretty confident and better and better. But early on, it was just this big question of like, what do you do in the therapy part of the equation? And so in collaboration with Adele LaFrance, an emotion-focused therapy expert and good friend of ours. She's deeply trained in emotion-focused therapy. I've done quite a bit of training in it as well. And she even created emotion-focused family therapy. We met in the eating disorder world. And so FCAP was in part designed for eating disorders, but also for depression, but based on this idea that this guiding principle of difficulties in emotion processing are often at the heart of many mental health struggles. And if we can support the clients in developing skills and confidence and moving towards their emotions, and leverage the power of the corrective experience, the healing power of caregivers, supporting them with emotion coaching skills, then we're wrapping the client in this really powerful therapeutic healing environment, and leveraging ketamine as a catalyst. But I don't know, what would you add to that, Steve, as a bird's eye view of FCAP?
Well, I've thought a lot generally about the kinds of psychotherapy we might combine with psychedelics, because we call it ketamine assisted psychotherapy or psychedelic enhanced or accelerated psychotherapy. And a lot of the folks that are doing the research, if you look at MAPS, their MDMA assisted therapy for PTSD manual, it's pretty common factors focused, right? It's pretty get out of the way of the medicine. There's not a lot of guidance or specific instruction about particular interventions, right? It's trust the inner healer, follow the medicine, support the healing process. So I'm really curious to see, as psychedelic assisted therapy becomes more mainstream and people try to adopt it and study it, how it pairs with particular kinds of therapy approaches. You see people talking about pairing it with acceptance and commitment therapy or internal family systems. That's probably the most trendy right now, just because Dick Schwartz has become a therapy celebrity, right? Appearing on all these podcasts and stuff. And we've talked to Dick. We love IFS. We love those principles, parts work for use in psychedelic assisted therapy. And, IFS hasn't cornered the market on parts work either. In FCAP, we do a lot of 2-chair parts work to help people learn about the difference between primary, secondary, and instrumental emotions, and help them experience, these different parts and the way they hold on to emotion. And as Reid said, move toward and process through emotion. And so we find that ketamine, for us in particular, it pairs well with this theory and this approach because of its tendency to loosen the internal binding around emotions, and it helps people move through and to emotions more fluidly, access these internal states and do work with them.
I'm curious how you guys, conceptualize this inner healing intelligence from the Groff and MDMA world when it comes to ketamine work. Do you really rely on that, or are you thinking about really kind of being, including more interventions, more kind of psychotherapy techniques? Because that lineage is very non-directive, but there might be times where you may need to be maybe a little bit more directive, especially if you're doing maybe psychedelic therapy.
Yeah. So from my perspective, you really do need to, no matter what therapeutic modality you're using, pay attention to or look out for the inner healing intelligence. And as a general rule, I just assume that all content that arises is meaningful, has some order, some secret order in it. And if it doesn't make sense, we can interpret that as our own limitation at that time, and we can keep revisiting it. Meaning making is a big part of emotion focused therapy, to be honest. And so we keep an eye out for spiritual mystical experiences, not just in the ketamine room, but in the mundane day-to-day life as well. And trust this belief that everyone has within them the innate ability to heal. And we're there to support the process, but we're not going to fix people.
Right. Yeah, we're not the fixers necessarily, but Kyle, you mentioned the difference between what we call psychedelic sessions or psycholytic sessions. Psycholytic meaning kind of a lower dose, they're more cogent and conscious. And I find that if I'm going to be more directive, if I'm going to try a particular intervention, that I agree with you, it's more of those lower dose psycholytic sessions that's more appropriate for that. And I found to be really effective. But those higher dose sessions, when I find myself making assumptions about where the client quote unquote should go, like where I should take them to help direct them to healing, I'm almost always wrong. Like I almost always screw stuff up if I try to be too heavy handed. So I've found that, I'm doing, like Reid said, the basics of keeping them safe and encouraging them to be curious, to let go, to open up to the experience and trust. So the old Rogerian idea that people will tend toward self-actualization and transcendence if you give them the environment to do so. That to be well is not something we have to teach people to do. It's something that they can remember how to do. It's in them. If we can help them peel away the negative programming and conditioning and trauma and all that stuff, that they'll find their way to health and healing.
Right. I know there's been like some critiques lately around like this, and especially with like in medicine. It's like, yeah, is this like a hard concept to understand, to learn from your perspective? Like, because it feels very, I don't know, sometimes like a little woo-woo. I don't know. I come from that Groff world.
Yeah.
I feel biased towards it, but I think for some people, it's like, what are you talking about inner healing intelligence? Like, what does that even mean? How do I trust that process?
Yeah.
And what happens if that process goes wrong?
It's a really good point, and I've found, because I like to bring science to the woo-woo personally. It's just like I love the
Nice.
intersection of these, and I find that like a personal crusade of sorts. And if you're looking at qualities of the inner healing intelligence, like it's nonlinear. There's no predetermined path to healing. We look for these themes and problems that emerge, and we trust the unfolding, that they're coming up in the order they need to be addressed. Could we get into literal debates about that? Sure. But it's also emergent, and you can lean on other psychotherapies like interpersonal group therapies, showing that like things emerge, we work with them, and often the corrective actions precede the insight. And there's this conscious participation through like multimodal experiential work, leveraging the inner healer. I love to go back to the old transpersonal psychotherapy literature from decades ago, and then look for little specks of this in other therapies, because I think it's such an important concept that I say bring on the debate, because we're big fans as well.
Awesome.
Yeah, I've had an interesting sort of, I don't know what you would call it, like a journey around this idea, because I started my training very Rogerian and client-centered, as I described, sort of trusting that self-actualization process. And then when I got into the military, it was very prescriptive, right? It was a very biologically reductionistic approach to psychotherapy. There was a lot of, this person's sick, we have the treatment. I worked in a medical center. There was an emphasis on cognitive behavioral therapy and other behavioral type therapies, cognitive processing therapy for PTSD or prolonged exposure for PTSD. And so I got kind of then steeped in I'm the doctor and I'll give you the treatment to heal your illness. And then after I left the military and started to get back, into the psychedelic assisted therapy world, I'm finding myself sort of coming back to trusting the inner healer. And as Reid said, bringing the science to the woo-woo and the woo-woo to the science, because that's really where psychology started, at least in my opinion. Like, we're the study of consciousness and the study of how the mind works, and we are applied philosophy. And so we need to, I think, make space for the unknowable and the unexplainable. And we study it. We apply the empirical scientific method like good social and medical scientists that we are. But I think we have to stay open, especially now that we're using these consciousness-altering medicines that are producing experiences that are ineffable and hard to describe, that lead to improvements in what we've been calling mental health symptoms that we haven't seen with our other treatments, whether they be medicines or psychotherapies. So I'm happy to declare what I don't know and open myself up to what might be possible.
Yeah, it just makes me think of William James with radical empiricism, right? I feel like that's kind of where the transpersonal is, right? We kind of need to put some of our notions behind and really just observe what's going on, and then try to understand it from different perspectives. Curious. So I know you guys have worked with ketamine for a long time. And I know some folks are thinking, once MDMA and psilocybin come online, there may not be room for ketamine. It seems like people are really kind of putting a lot of focus on MDMA and psilocybin. What do you think ketamine it can be used for? What's the benefit maybe over some of these other medicines?
Yeah, I'm pretty confident that it's not going away. That's for sure. It has such a unique use in psychiatry and mental health. Um, Steve once coined these three buckets of the way we use it that I like, the three P's of psychiatric, psychedelic, and psycholytic. And psychiatric meaning like S-ketamine exists as an FDA-approved medicine for treatment-resistant depression or MDD with suicidality. And you can give it, and it has rapid antidepressant properties, and there's good data on preventing some relapse as well. And as I mentioned, we've probably given 10,000 doses of it since it came out, and all leveraging insurance. And there's a lot that we could add to the equation. We try to bring in all the therapy we can still, but in the psychiatric bucket, there is a use of ketamine as well as a rapid antidepressant for someone in crisis, and of course, the more KAP, the more therapy, the better. But then in the psychedelic realm, ketamine has unique properties. Like, sure, it has a shorter neuroplasticity window or critical period, like some of the Gould-Dolan work highlights compared to classic psychedelics. But it also has this calming property where, like, people going into their first psychedelic experience. I've had countless individuals just freaked out about that uncertainty, but then just having this joyful experience of flying through their ketamine journey and coming out with some skills and confidence, and a lighter mood, a cloud lifted perhaps. So it's a brief experience. It's easy to use. It pairs well with a lot of therapies, and we've explored it for all sorts of different indications that I'm confident it'll have a role, even when all of these medicines are out there. But Steve, what do you think?
Yeah, me too. I think, you mentioned it being a briefer experience. It's 45 minutes to an hour for a typical, IM ketamine journey. And you compare that to 4 to 6 hours with psilocybin, or, 8+ hours for MDMA, 12 hours for LSD. I know that MAPS came out with their feasibility study suggesting that MDMA, even though it's going to take a lot of resources, is going to save insurance companies and the world money, which I'm excited about that data. But I think just because of how brief the experience is, I think it's still going to be a cheaper and more accessible psychedelic assisted therapy tool than some of these other medicines for a long time to come. Also, I think it's qualitatively a different experience. We call it a psychedelic. It's not a classic psychedelic, different mechanisms of action in the brain. Its dissociative effects, I find, are, they're different enough from some of the other psychedelics that if a person wants a break from identity and from their bodies, then and to accumulate or experience the insights that are on the menu for that kind of experience, ketamine's a great tool. Also, I'm excited for the future when we might be able to explore and study combinations of psychedelics. I know in the underground world, people will use ketamine before their DMT trips to calm before they smoke the toad. They do some ketamine, and it sort of makes that ramp up, that rocket ship into God consciousness, a little bit easier to ride.
Yeah, or I hear pretty other common is like MDMA before psilocybin to kind of like take the edge off there. Yeah, I'm excited about those combinations too as research moves forward there. Reid, something you said just made me write down resourcing with ketamine. And I think I've heard that from maybe a few of my other clients where it felt pretty resourcing. And it makes me think just around, the whole study with frontline workers and just thinking about regular self-care and just getting that time to kind of shut off for a little bit and resource. And I wonder if it could be kind of like a tool used in that capacity instead of like always needing to go in and do maybe this deeper healing work or getting into those deeper transpersonal realms, but just feeling this sense of relaxation. Like I know I've had my clients say, wow, that was just like a really relaxing experience. And I felt like I needed that for a little bit.
Yeah, I like that. And that's one of our teachers and mentors and friends is Phil Wolfson. And I think he was probably the first one to really help me see that ketamine can present a timeout from ordinary mind. And since then, since I've gone deep on the literature for years and seen that, yeah, ketamine actually turns off lateral habenular burst mode, giving someone a real break from this overactive, stressed out state that we can get stuck in modern life, as one example. Or it also, through its like calcium channel mechanisms, the higher the dose goes, that you start to slow down thoughts and rumination decreases. Sure, you go too high, you're in anesthesia realm, and like some of those sheep studies, you could like flatline someone's thinking processes. But you can give someone a timeout from some of this intense monkey mind stuff that's going on, and that can be powerful. That can be a much needed break when you feel completely overwhelmed.
Yeah, I think those are the reasons why it's particularly helpful for treatment-resistant depression, where we think it's treatment, quote unquote, treatment resistant, because of the tendency toward rumination. Like it's hard to escape the swirling maelstrom of those thoughts. And for conditions on the sort of the other side of the what is Carhart Harris's entropic brain sort of spectrum, right? It's like OCD and eating disorders, where you're held captive by the insistency and persistence of your thoughts. So ketamine, as Reid said, slows it down, and you can get a break from it. And we see this with a lot of our Spravato or S-ketamine clients who are coming in. They're getting that psychiatric treatment approach. Maybe they don't have a ton of therapy or therapeutic support. We try to, as Reid said, give them as much as we can. Some people don't want it, but a lot of them have said like they want to keep doing Spravato, in part because it's helping with their depression from the neurochemical perspective, but it's also just a break from normal consciousness. How many of us can have 2 hours in a day where we get to chill? Very few of us.
Yeah. I know it's a little bit more controlled in these clinical settings, but I wonder, is there any worry or concern around any of the addiction potential with ketamine?
Yeah, I think there is. It's a very valid concern because ketamine is a drug of abuse in most parts of the world, and if left unchecked, I've seen it firsthand. I've seen people escalate their use to very problematic territories. It's not most people, but we've certainly always wanted to and needed to have checks and balances in place to prevent that as much as possible, both on the screening front, like screening out as much of the significant risk factors, while also acknowledging that ketamine can be anti-addictive, and there's a growing body of evidence to support its use in treating substance use disorders. But if there's poorly controlled active substance use, polysubstance abuse, dependence, and no therapeutic support, and we're not going to just go into ketamine work with someone, or we're certainly not going to send it home, but we do send home a lot of ketamine doses, not for kind of remote experiences, but for maintenance with an important medicine for accessibility when there's a known client and a vetted caregiver and a very careful treatment plan and contract in place on the appropriate non-daily use and frequent visits with prescriber therapists and all that.
We've formalized those checks and balances, with strict standard operating procedures that we train our clinicians on. We train our clients on them too, right? Expectations for follow-up. As Reid said, if we do send ketamine home in the form of a compounded nasal spray or a lozenge, it's only going to be with the client we know well, that we have regular follow-ups with, that has a vetted support person. So it sets us apart a little bit from these take-home ketamine clinics that we see popping up, that I think some of which are doing great work, but we just approach the medicine a little bit differently, and would rather have keep close tabs on our clients during the ketamine experience. And I think some of those, I'm not trying to crap on any of these companies. I think some of them are doing a great job and are increasing accessibility and take seriously keeping these people connected to therapeutic resources. But yeah, we're trying to take the abuse potential seriously, and that's the way we do it.
Awesome. I'm looking at time, and I also definitely want to touch on, you guys said that you're working on an LSD for anxiety study or have some news around that. So I'd love to hear more about what's going on in that world.
Steve and I and our colleague Paul Thielking were just at the investigator meeting for that study a couple weeks ago, and we did a press release about it within the last month or so, that we were selected by MindMed as a site for their LSD for generalized anxiety disorder study, which is just exciting. And I've got to admit, feels monumental, it's a little mind blowing to think that it's finally coming back, because we've, like we've geeked out on the history, talked to people from back then, and can see the potential, and really love looking at from Albert Hoffman and beyond, and Humphrey Osmond, what was done with the medicine, and to have it come back, and to have it come back for generalized anxiety disorder is pretty neat. So we're excited. We're working on our Schedule 1 licenses, adding that on, because we've been working with psilocybin lately, but yeah, it's exciting.
And that's probably some of the first, I mean, I haven't heard of too much like LSD psychotherapy research here in the States in a while. I know Dr. Peter Gasser was doing stuff over in Switzerland. But
Yep.
Has there been any other LSD research here in the States probably since it shut down?
No, this is the first one to my knowledge, and the Basel group is doing a lot of work with MindMed. They're the ones. I think Gasser was one of the trainers remotely, at least on Zoom during this meeting. It was amazing to hear his stories of the LSD work from the room where he does it in, or showing the setting he uses. But they did that in Basel. Like, these research groups did the LSD versus psilocybin, different doses in the same individuals study. They have an LSD for ADHD, kind of lower dosing, frequent dosing study that's
That's
just
really
starting.
interesting.
Yeah, that's fascinating.
Is that kind of like, what's the dose range for that?
Well, I don't know exactly. I have a general range. I don't know if I'm allowed to speak about it, but I can tell you it's lower dosing and more frequently is the protocol. But this LSD for anxiety one in the protocol stuff that's been published is both. It has a dose finding and efficacy component. So there's a couple dose arms, and it gets up there. Yeah, and what's interesting is seeing the reaction. People's reaction is, wait, that for anxiety, because of the anxious experience that some people have, I think is pretty funny.
Right. Yeah, I was gonna ask, like, why anxiety disorder for LSD? Because that hasn't really been explored too much, right?
Well, when Sandoz sent it around to psychiatrists, clinics, therapists across the U.S. and Canada, they provided 2 stipulations. Like, this might be a nice experimental model of psychosis. Well, yeah, I mean, we're not going to, that has its role, but that's not the way we use it clinically. Or it can be useful for neuroses. And there is this paradoxical, like, the only way out is through, or this shake it up to work with it kind of phenomenon, that sure, you could have an anxious trip or experience, but there's some good preliminary data and rationale to support its use that I'm excited to see how it goes.
Yeah, to me, it makes complete sense to use something like LSD for anxiety, because what we think perpetuates something like generalized anxiety is what Steve Hayes of ACT might call experiential avoidance. That we don't want to feel these intense, feelings of fear or embarrassment or rejection or whatever it is. So we worry chronically. We get addicted to worry itself, keeps us safe from having to do scary stuff. And the LSD experience is just, for a lot of people, is just going to crack that open. and give you an opportunity to face your fears, so to speak. It's like exposure therapy on, I don't know, on psychedelic steroids.
Is there anything that excites you about LSD versus, like, say, psilocybin, ketamine, or any of the other medicines that you've worked with?
That brings up a point that I was thinking of earlier when you asked about the role of ketamine. Is I was just thinking of the different pathways that the broader definition of psychedelics encompasses, or the different pathways to induce hallucinations, even because I'd say there are three main ways, and ketamine is the dissociative anesthetic way, just like PCP is. And there's this NMDA mechanism, and it has a lot of visual stuff. If there's a delusion component, to use the psychotic terms that people don't like to use, but I think it fits, it's more mixed. Like there could be some paranoid, there can be some mystical. And the insight is variable that comes along with it. Whereas a classic psychedelic like psilocybin, LSD, there's more insight naturally tied to it. We have to work harder with ketamine. It comes more naturally with LSD and psilocybin, more mystical delusions than paranoid, and of course has this predominant 5-HT2A mechanism. And then you compare that to like the third way of dopamine, meth, cocaine, very paranoid delusions at the high doses, more auditory hallucinations. It's agitating. You're not getting insight out of the equation. But LSD, I think, is just a fascinating classic psychedelic that's some call more promiscuous than psilocybin on the receptor front. And with this long experience, like Steve's alluding to, where you can really do some deep work.
Thinking about bringing LSD to market, I know one of the challenges is definitely the duration, right? I mean, that's pretty extensive resources on the clinical side, and could probably be pretty expensive to have a treatment like that. But I wonder, other than that, like any other challenges of maybe trying to bring this substance to market? So I guess something else that I think about is just the taboo around LSD versus psilocybin culturally here in the US.
That's what I was thinking of, Kyle. Like, I think it was strategic that a lot of when the psychedelic renaissance began, that researchers were choosing psilocybin over LSD as the things to study publicly, just because LSD sort of evokes in a lot of our consciousnesses, especially those of us that were raised during the war on drugs and the DARE program, that like LSD is this wacky thing that makes you jump off buildings and peel your skin off. But psilocybin, what the heck is that, right? A lot of people wouldn't recognize that as magic mushrooms. So yeah, I think a lot is being done and has been done to change those biases and change the public perception around psychedelics generally. But I think that would still be a challenge if people say, they look at the menu of services on offer and they see acid is one of the things they can do to treat their anxiety. They might pause.
Yeah, I think it's, I don't worry too much. I think there is more of a perception hurdle than with psilocybin, and especially when you can talk about the mushroom tie, even if it's a synthetic psilocybin that's being given. But I don't know. The new generation is very open to LSD and all psychedelics, and the data. If you look at the public perception surveys, like I've seen the LSD use increase like 50+% year over year over the past several years, whenever I see data reported on it. And I think there's an openness to anything for our collective mental health, because our collective mental health is kind of struggling these days.
Yeah, and I guess with that, I mean, I guess my one thing thinking is like, yeah, what would treatment look like? If we're looking at like 10 to 12 hours for an experience, would that require somebody to be monitored overnight if you're starting it in the morning into the evening? And just kind of curious.
The protocol doesn't require overnight stays. It's like the same as the psilocybin protocol, but you have some more hours added on. So it's more expensive due to therapist or monitor time, but otherwise it's about the same. So that there's a hurdle there, and to be determined, like how scalable that is and how scalable, accessible MDMA and psilocybin are, but I don't think it's that drastically different.
Yeah. And are there any other indications people are looking at other than this anxiety treatment with LSD?
Well, traditionally it was studied for alcoholism, like 1,000 patients, a dozen studies or so. Um, with good data, I think there was even a meta-analysis done by folks um, looking at LSD clinical trials showing, I think, an effect size like a pretty robust one of over 2.5 times higher than treatment as usual with acamprosate for alcoholism. And so you could save a lot of lives with LSD for alcoholism. That's probably, people estimate, has killed 100 million people as a condition. So I think that's one. I think end of life anxiety, there's some potential there. ADHD there's a study kicking off that I have no idea. That'll be interesting. I'm fascinated. Generalized anxiety, and you could think about a lot of related conditions.
Yeah, I think one of just as a callback to the hurdles of the time commitment for something like LSD treatment, a couple more hours tacked on will be more expensive. But having been a facilitator in some of our psilocybin clinical trials, therapist stamina is an issue we're going to have to address too. Like, that's a long time to be with somebody the way that you ought to be with them if you're going to do this therapy well, right? Very attentive. And the way the protocols are designed, you've got to be in there. It's dyads, it's therapy dyads, you and a therapist partner. You got to be in there the whole time. We don't leave them alone. If you have to go to the bathroom, somebody else has got to come in and make sure we always have two people with them. So, 6-7 hours for the psilocybin clinical trials. We'll see. We'll see what it feels like to sit with somebody for 12.
If you were to compare it, because you've done this, like psilocybin, a psilocybin session versus a day full of 7 individual therapy clients, what one's more taxing, draining for you?
Ooh, that's a good point. Because I've done, back when I was in private practice, I had days where I saw 10 therapy clients in a day. And it burned me out real quick. I would rather do, I'd rather do 1 7-hour psilocybin session than, 7 or 8 individual psychotherapy sessions for sure.
And maybe your work week gets really interesting when you have 3 12s doing LSD work and you get 2 days off and you're full time. I'm not saying that's going to happen anytime soon. But
is that a promise? Cool. Are we making a contract right here?
It's official here on Psychedelics Today.
Yeah, exactly.
You heard it first.
Yeah. I mean, that does bring up interesting questions around what do people's psychedelic therapist work schedules look like, right? Because this can be very taxing work, but I think you bring up a good point, like having clients back to back 10 hours. That's probably just as taxing as sitting with somebody for 6 or 8 hours. But I think with psychedelics, and I'm curious to hear some of your opinions too, there seems to be more of that openness and maybe some more intense energies that facilitators maybe need to sit with. And I think that's where a lot of like that self-regulating techniques come in, and really trying to also do some of your own work while you're in the session of like, okay, I'm getting activated here. There's really, really intense energies coming up. What do I do?
Yeah, I've been querying people, our clinicians coming out of the psilocybin work, having just worked on USONA's phase 2 study. And just because it's a fascinating question to me, and therapist burnout is a big deal. It's something we deal with on a day-to-day basis, trying to open up access to more KAP and more individual therapy in general, with the pandemic like fresh in all of our minds. And I got to tell you, the general sentiment coming out of a whole 6-7 hour session is like, I loved that work. And there were periods of time when they were deep in their process, and sure, I had to be there, but I could sit and it felt like a meditation. It felt like almost recharging. And sure, if they have a very difficult experience, that could be some of the most taxing work you've done in a long time. But I personally have a hunch that more psychedelic therapy work is going to be better for therapist job satisfaction and retention. Just my guess.
Yeah, and you mentioned doing your own work. You know, we talk about this in our Foundations of KAP training, the importance for helpers, guides, facilitators, clinicians to do their own work. You don't have to be a perfected being in order to be a professional helper, but it's important to know your triggers and to address them, know how to calm your nervous system. And there's a conversation in the training world around whether or not psychedelic therapists should have psychedelic experiences. You know, should they know the medicine that they're working with? I feel like it's not. Reid and I have talked about this a lot, but it's not required. Like it shouldn't be like a box you have to check to get certified. But I think it's tremendously helpful. So, you know, is there a way that we can include experiential, you know, experiences with the medicine that you're being trained on as part of the training process for its own healing properties for the helper, but also so that you can relate to what your client's going through. And I know that there are some, like MAPS was trying to get MDMA experiences for the clinicians they train. And I think as part of your VITAL program, you encourage people to get their own experience, whether it's breath work or whatever.
Yeah, trying to leave that open because I know there is that kind of ethical concern around, you know, should somebody take a drug that they may not want to take, and some people can, right? Maybe there's some medical issues where it's just not appropriate to do that, and so could other techniques be a little bit safer that exposes you to some sort of holotropic state of consciousness that can give you some more insight in how those experiences are for people? And it kind of made me think about a question when you use the term psychomimetic. That was the first thing that popped in my head was, I wonder if we'll bring back that whole framework of having, training clinicians with LSD again to understand what it feels like to be in that state. So I guess we're naturally touching on this topic of having one's own experience to understand what the inner experience is like for clients.
And why do you think we don't see more breath work in clinic, for example, or non-medicine induced altered states?
That's a good question. I don't know.
I mean, implied in the question is probably an encouragement that we should, right? It's an incredibly powerful tool and more than just an analog for a medicine-induced psychedelic state. You know, I know people that have done had lots of non-ordinary states of consciousness, and some of them will say that their holotropic breathwork sessions were the most evocative and helpful.
That's what turned me on to it. I was pretty blown away by it. I think, how much research has there been done around like that type of style breathwork in clinical? Not much. I wonder if that plays a role in people wanting to incorporate it into the clinic. But I think it could be really, really helpful. I definitely include some breathwork here and there with some of my clients, kind of as a primer before KAP sessions sometimes to get them associated with a state if they're completely new to it. But yeah, I think there's power there. So I know we're heading at time. Steve, do you want to talk any more about your introduction to ketamine training before we wrap up here?
Just to let people know that the prices and launch dates are not on the website quite yet. So if you go to the website, cedarpsychiatry.com/edu, you can put your name on the wait list and we'll let you know when it launches. We have a variety of offerings there, and one of them is just a self-paced online course, similar to some of the courses you might find on Psychology Today or something like psychedelic.support or Fluence. But it's drawing from our experience, having led a lot of ketamine-assisted psychotherapy as a foundations course, just to kind of give you a nice rock solid foundation if you want to do this work.
Awesome. How many hours is it?
We're on our second draft of this course. The first draft was about 7 hours of video content with, we give you our handouts and our checklists. I think as we revise this, it's going to be longer, probably about 10 hours of content.
Wonderful.
And then I'll take this opportunity to shamelessly plug our podcast. Reid and I host the Psychedelic Therapy Frontiers podcast. It's one of the favorite things that we do. And we had Kyle on our podcast. It was a great interview. So encourage people to find that on YouTube and anywhere else that you listen to podcasts, Psychedelic Therapy Frontiers.
It's a great podcast. So definitely give it a subscribe and listen. Anything you guys want to close with? Any final thoughts other than plugs? Steve, I guess we'll start with you. If there's any final closing thoughts here.
I appreciate the opportunity to be on your podcast. I've been listening to you folks for a long time, and I think you provide a tremendous amount of value to this community in this space, destigmatizing and bringing experts to bring the knowledge of this work and how it's progressing, and we can all sort of join together and hopefully usher this psychedelic renaissance into the modern age responsibly and powerfully. So yeah, just thank you for the opportunity to be on.
Thank you. And how about you, Reid?
Yeah, I just echo that. I've been a fan for a while, listening for a long time, and it's really neat to see where we are now. Like with psychedelic therapy is in everyday mental health care in many ways, more and more. And to look ahead to what's coming is really exciting and inspiring. So I'd say, yeah, thank you for all the paving the way work you've been doing and continue to do. And it's really great to have these conversations and think about what it's going to look like, because we do have to band together and figure out how to navigate these obstacles in a good way.
Yeah, well, thank you. It's very humbling to hear that you guys are both listeners of psychedelics today. So I appreciate all the support. So Dr. Reid Robison and Dr. Steve Thayer, thank you so much for being here. I really appreciate it.
Yeah, thanks for having us.